evening, and welcome to tonight's DE Solutions Lab. I'm Dr. Pam Maragliano Muniz, Chief Editor for Dental Economics Magazine, and I'm thrilled you've joined us here tonight. So tonight's topic is an awesome one. It's a clinical topic. It's something that we can go to work tomorrow and hopefully implement right away. And with us tonight is Dr. Dimple Desai and Gregor Connell from Voco. Welcome, you two. I'm so glad you're here.
Thank you. Thank you for having us.
So as we get started, just a couple of housekeeping things for this event. The spirit of this event is to get your questions answered. This is peer-to-peer, us chatting after work. So please, if you have any questions, throw them in the chat, enter the Q&A, whatever makes you happy, go ahead and do it because we want you to feel like you are leaving with a little pearl that you can take with you at work. So please, by all means, the purpose of this is to be interactive. So interact with us. We want to hear from you. So definitely please do that. So go ahead, Dimple, let's get started.
Okay, so tonight we're going to be talking about Stamp Symphony, aka Stamping Sexy Dimples into the Occlusion, harmonizing tradition and innovation. I have to give my kids a little shout out here before we begin. This is my son playing for Elise on the piano. As I spoke with Gregor earlier, piano is really a torture for my kids, but they've been playing since they were 4, and I'm pretty proud of them. This is a classic German composer, so I just had to brag a little bit. So tonight, I'm going to give you a little intro about myself, discuss the products that I used, the technique, and the reasoning. So imagine if you could replicate David's hand, the intricacies of it, the depth of the veins, the cuticles of his nails, just every little detail in composites and doing posterior teeth. So we all know when we do posterior composites, I always tell my assistants or my front desk, please don't put a class 2 or a class 1 at 4 or 5 o'clock at the end of the day, because it's going to take me a lot longer to do that versus prepping a tooth. And by that time, you're just fatigued and just the time and energy you put into it. So imagine if we can do that and replicate the patient's existing restoration to with what they came in with and now, and do it in a more simpler fashion and technique. So let's get into me a little bit. Who am I? So this is me. This is COVID 2020. And I really love this picture because this is really a moment of when I became who I was and just neurotic in my ways. So in 2018, I started to practice from scratch in Newport Beach, California. And I decided I'm going to do everything at once. I went to my first American Academy of Cosmetic Dentistry meeting in 2019, and I realized I want to become an accredited member. And shortly thereafter, of course, 2020 hit. Just like the rest of the world, I shut my practice down. And right when that 2-year peak is going to hit in my practice, boom, I'm hit with COVID. And now I'm hit with goals that I don't really know how to achieve or where I need to go or what to do at this point. And if you know me, I'm a type of person that I can't sit still. Like, I'm constantly on the go. So I told my assistants, I said, all right, pack up whatever models we have in the back. Let me see if I can buy a waxing unit off of eBay. So that's what I did. I took out my old curing light. As you can see on the lower left, it still has a wire attached to it. And I also bought an electric handpiece off of eBay, overpriced, of course, because maybe other people were thinking the same thing as me. And I brought home whatever composite I had in my office. And thereafter, all I did all day was just practice anterior composites, day in, day out, because I just didn't feel comfortable with really how to manipulate the composite and line angles and so forth. So, and you see, I took notes with that notebook. Every time I see this picture, I just laugh. And on the other side of this dining table are my kids that I'm homeschooling, because I had a kindergartner who never used a laptop, who now had to use it and do all her homework. And I had a 3rd grader. So it was just chaos all at once. And so every day I had an agenda of how many teeth I wanted to prepare and how much composite I wanted to do and what I can do to get better every day. So the 2 months that I had off, this is what I did. And of course, 5 o'clock would hit, so it was happy hour. So you see that bar stocked in the back. Yeah, that was empty. by the time COVID was done. And so 5 o'clock would be happy hour. So my neighbors would come out and say, Dimple, what are you doing? Why aren't you out? I'd say, I'm not ready yet. I got to fix this line angle. It's just not perfect. And you become like this obsessive person that you just want to perfect it. But I did have my fun, I'm not gonna lie. So that was me during COVID. And a year after, I did become accredited with the AACD, and that was a journey that just opened many doors for me. And I met awesome people and just colleagues that were like-minded. In addition to that, I did a little bit of drawing. So I was trained under Pascal Monnier, and he's very into visualizing the natural tooth structure and mimicking what nature gave you. And so I did a little nice lateral on the lower right. And so those are my things that I achieved during COVID. So I'm forever grateful for COVID and just bringing my family closer together and learning skills and pushing myself beyond the limits. Okay, enough about me. Let's get into tonight. So what products did I use for my stamp technique? So on the upper left, you'll see the Admira Fusion X base that I used. And thereafter, I used the Vocosed Acid Etch 35%. The Futera Bond U. What I like about the Futera Bond U is a single dose package. So it's very convenient. It's very easy. And you just tell your assistant, press here, dispense the material, and it's easy. So what I mean by that is you want to limit your stress factor in the treatment room. And Pam, I'm sure you can relate to this, right? Is that you don't want to get stressed out with your assistant dropping maybe 5 drops of bonding agent when you really just needed a drop, right? Things like that start to add up, obviously, as a business owner, and you just think, well, we didn't really need that much. So the fact that Futera Bond U has made dispensing so much easier and less stressful mentally, I think that that's a huge plus in my practice. Like these are little nuances that really start to add up, right, Pam?
Absolutely.
And just the other day, actually, I hired a new assistant, and I think she dispensed about 5 drops, and I was like, oh, why are we not using the Futera Bond U? Where is it, guys? So it's just little things like that. Thereafter, I added or used the Admira Fusion Extra onto the tooth surface, used Snoop Carey's detector to make sure all of my decay was removed. And lastly, the ASAP polishers by Clinician's Choice to polish my nice occlusal surface. So the technique, let's get into the meat of this. So this is David, hence David's hand in the beginning of this presentation. My patient David came in and he's referred to me by another awesome patient. And he said, hey, doc, I'm having a little sensitivity on the upper left to cold, to sweets, not sure what's happening. So of course, I did my exam and I noticed that there's penetration of that central fossa on number 14. So I said, okay, David, you have a cavity. And he's like, okay, what do we got to do? I said, let's do the stamp technique. So that's what we did. So he had no idea what he was getting into. I just said, David, it's going to be a little, maybe an extra 45 minutes of your chair time, but we're going to do an awesome presentation. I promise I'll give you a shout out. So as you see, David has a pretty, his anatomy is a little different. What do I mean by that? His occlusion is not ideal. So we're all taught the ideal occlusion of making sure the cusp tips hit, the lingual cusp tip with the opposing arch, the central fossa is hitting, but that's not our everyday practice. We're not going to have that every single day. And let's be real, probably never. Nobody's going to walk in with ideal occlusion. So shortly after we finished this technique, by the way, I did put David into clear aligner therapy, but to mimic what he has and minimize my chair time thereafter was very important to me. So like I said earlier, if you put a class 1 filling at the end of the day, it's not the technique and it's not the process. We all know we can do it, but it's the finessing of it. Okay, so you have a patient who feels that they may be numb, they may not be numb, but they're hitting this, they're hitting that, and it's just very tedious. And so I wanted to simplify this technique and make it a lot easier for us as clinicians. And I mean, obviously I didn't create the wheel. Many clinicians have done this. And so I thought, let's try this. So I said, okay, David, let's isolate your tooth. Let me get some awesome photography for a future presentation. So that's what I did. I rubber dammed my patient with True Dental Dam by Clinician's Choice. And then I lubricated the tooth. So step 3, I just used regular petroleum jelly, lubricated it with a nice brush. And I did that so that we don't have adhesion of the composite material, that Admira Fusion, onto the tooth. And so I took a nice little micro brush and I embedded it into the occlusal surface, and then I flowed the Admira Fusion into it. And what I like about this particular flowable is that you don't need to cure it incrementally. So you can cure it at a bulk of 4 millimeters. So why is that important? So again, it's about minimizing your technique thereafter. So if I'm placing the micro brush and flowing this Admira Fusion X base, then I can flow it comfortably, reliably at 4 millimeters and cure it. And like I was talking to Gregor earlier, I always cure everything. So I don't want to look away and cure and so forth. So I can bulk it up and cure it at the end. So I know I have a nice, reliable stamp that's going to be created. And so that's what I did. And that was my stamp that I created. So now it picked up onto the microbrush, and these are different angles that I took the images of. So now I'm going to put that to the side and move on. So yes, it's an extra 10 to 15 minutes, maybe. If you get quicker, it'll be 5 minutes, but at least you have it down to now you can secure his occlusion where you can minimize the adjustments thereafter. And what I used to do, let's back up. What I used to do is I would say to the patient, okay, let's chew on this articulated paper and think that I have a photographic memory and try to remember all the occlusal spots. But let's be real, by the time you remove the decay and you're looking through your loops that are 10 plus magnification, you're not going to remember everything to that exact image that you've imprinted in your head. So this technique really takes that security of pretending to remember exactly out of your element. And so you can go on to move on to do your work. And so this is what I did. I put on Snoop Caries detector by Pulp Dent, made sure I removed all the caries, verified it again in step 6. And this is a nice clean image of it in step 6. Once I knew I securely removed all the caries, I disinfected the tooth with an air abrasion unit. This is the Aqua Care unit. Cleaned it out very thoroughly, and then rinsed it. And then I applied the Vococed Etch 35% around the enamel for 10 seconds. And how do I know it's 10 seconds? Because I do have a timer. So I don't start the timer until I tell my assistant, go. And so they're already ready with their clicker on the finger, or finger on the clicker. And so 10 seconds, then I let that penetrate. Then I add another 10 seconds onto the dentin. Thereafter, I'm gonna rinse really well. Only dry the enamel, keep the dentin moist so that way the collagen fibrils are nice and erect. Apply and scrub the Futerra U, which is again another self-etching adhesive. And I'm sure Gregor will get into that later. And then once I've cured that, I'm gonna just wet the base of the floor and the wall. So not at even less than 1 millimeter increment with Admira Fusion X base. And then I'm going to pack in the Admira Fusion Extra Packable. And I'm going to overfill it. So what I want you to appreciate with this Admira Fusion Extra is that, I always say this, every time I use this material on the posteriors, I always finish and I say, damn, that looks good. And it's not me, it's the material. And then I'll look at my assistant and I'll say, look at this. And she said, always looks good. I said, I know. And then I look at the patient, I said, listen, it's not me. It's the material that we use. It's a nano or Mr. property, which I don't say because it goes over their head. But my assistant knows that and I know that. And it really gives a ceramic lifelike appearance. So there is no day that goes by that I don't use this material on the posterior teeth. And it just simplifies your process and just makes the tooth look so much nicer. And the fact that it's bulk fill, when we learned composites with Monnier, like it was very thorough in the sense where, you want to cure incrementally, create the zigzag pattern. And with the bulk flow property, you don't really need to worry about that. And that's what I like. I can fill it up, cure it comfortably at 4 millimeters, and I'm okay. And I know it's going to cure and I'm not going to have post-op sensitivity. And you may ask, how do you know that? Why? Because I don't have anybody calling my office the next day. So I can securely say that. Now, moving on to step 12. So I've overfilled it, as you could see. Thereafter, I'm going to place a nice thin Teflon tape covering over it. And then I'm going to go back and get my stamp that I created, push it into the occlusal surface, and then lift it up. So the Teflon's really like a barrier. That way we don't have any adhesion. Lift it up, remove the Teflon tape, and there's the stamp, just like David entered in step 15. And then I'll remove the excess, as you see in step 16. And that's the instrument that I do use every day. It's by Ivoclar, and it's an optroscope condenser, and it's made out of styrofoam, and it's just awesome to manipulate any composite. But again, all I need to do is remove the excess. And then I like to always apply a little tint here and there. So I applied a little bit of a yellow tint just to create a little bit of a groove. And then I cured it. And that was my final occlusion and post polish. So once I cured the last step, I bring David up at 45 degrees, have him chew, and this was exactly what I got. And I polished it up with the ASAP polishers. And the fact that, yes, you have to do your homework a little bit in the beginning, create the stamp technique, but I'm done. David is not going back and forth with me saying, I think I feel this, I think I feel that. And we're done. So once I showed him this picture, because I took pictures along the way, he was pretty happy. So what's my reasoning behind this madness, and why are we doing it? One, the bulk flow benefits in these large class 1 restorations, like I said throughout the presentation, is that you don't have to worry. You're not doing the zigzag pattern and worrying that you need to make sure you cover this angle and that angle and prevent any sort of shrinkage factor. I think that the beauty of Admire Fusion is that it really allows you to do this comfortably. And when I tell you I use it every day in my posterior teeth, it's no lie. So it makes it simple. I don't have to think about it, and I feel very secure that I'm not getting a phone call the next day that I might have sensitivity. Now, what I also say is when I cure, I always make sure I cure any sort of posterior or any tooth. I am always holding the curing line. I'm sure we all have assistants. They're all great, but just I have control issues, so I'm holding that curing light just so I know exactly where that curing light is aimed, how far it is, and my material is getting cured accurately. The time efficiency. So again, the 4 millimeter incremental cure. So again, starting from the beginning, when you creating the stamp technique with the Admire Fusion X base, you're not going back and forth curing a little bit because your hand can move when you're creating it. So I can just bulk it through and form it around the way and just make sure that it's all secured and cure it all at once. And of course, on the occlusal table as well with the Admire Fusion Extra. I think when I say that the aesthetics of it was pretty nice, if that was my tooth in the posterior, I would be pretty happy with that. I mimicked what was there, minus the brown staining, because I'm in Newport Beach. Nobody's going to want brown staining on their occlusal surface. And the fact that it's easy to polish and that it really just is simple. It's a simple technique, and it just, the tooth is dictating the shade, and it's just this beautiful, vibrant image. Like I said, again, every time I'm like, God, that looks really good, but it's not me, it's the material, because it just makes my life that much more simpler, and I don't have to guess and pick which shade I like or choose from an array of Vita shade tabs with different composites and say, I like this or I like that shade. It's simple. It's just one shade. Recreating the precise occlusal morphology with ease of adjustment. So what do I mean by that? Okay, I'm sure, Pam, you can relate. Gregor, I'm sure you know as well. So you have a patient, sit them up in the chair, and you say, okay, go ahead and chew on this articulate paper. And they're numb, but they're not sure if they're numb. They may be numb, and they feel something. And you're going through this back and forth game with them. I think I feel something a little bit more here, a little bit more there. And then you're adjusting because really it's now like 5:30 and you're like, okay, it's time. Like we got to go. I've spent an hour on this tooth for no reason, right? And so you're dealing with this patient who may know, who may not know. And at the end, the answer is, you know what? I'm numb. can I just call you tomorrow if I feel something? But the process of now worrying that you may have get that phone call and then your assistant has to set up. They have to bring out the handpiece. They have to bring out the burrs that you like. And let's be real, we all own our own businesses. It's costly. You rather get the job done the first time correctly than to bring the patient back. And not only is it annoying for you, it's annoying for the patient. So I rather make sure that I get everything down securely the first visit and be done. It's just a class one, but it's not just a class one. It's a class one that you want to make sure you don't ever see again. So less chair time, more cost efficient. Pretty much what I just mentioned. You just don't want to repeat the process. And at the same time, you're not trying to bring that patient back during your lunch just to make an occlusal adjustment. So this is a simple, secure process where you're not going to get that phone call and you're not going with this back and forth game with the patient and saying, I may feel something, I may not, maybe, maybe not, I don't know, I'm numb. So that's why I believe in this reasoning and just to minimize time efficiency and being cost effective at the end of the day. And at the same time, if your patient has to come in again, they're gonna have to take off of work, they're gonna have to come during their lunch, whatever it is, it's just not beneficial for both parties. So this is David. David says, thank you for listening. And here's my Instagram handle. And now let's listen to some Google.
Okay, so that's where I pop in, I guess. Yeah, within our company, my name's Gregor, but within my company, somebody started saying, just Google it, just call Gregor and ask him the question, he'll give you the answer. And the reason I do that is I've been doing this for 35 years, and it's all about materials. And the thing that's kind of wound me up about dentistry 35 years ago was I'm not an OCD individual. Not that there's anything wrong with being OCD. I'm just not that person, but I need to know why things work a certain way. Don't just tell me it works, explain to me why it works that way. And then I need to understand it. And then once I understand it, then I can share that with other people and help them understand how it works. And that's just been the way I've been wired since birth. So when I got into dentistry, I started saying, well, there's a clinical challenge there. Well, why does that not work? And dents, well, here's the problem. I said, well, we need to find a solution for that. And here's the thing about the dental industry. Whenever you have a problem, and I've been in this, as I said, for 35 years, but I've been lecturing for about 25. I've met probably tens of thousands of dentists around the world. None of you actually have material problems. You all have clinical problems. But when you look at the dental industry at large, be it a manufacturer, a retail rep, whoever who's calling in your practice, as soon as you say something doesn't work, what they want to do is give you another product instead of dealing with what the issue is. It's easier just to switch it out and try something different that you know a bunch of other people love than trying to dig into your clinical issue. I've always gone the other way. I've gone and said, show me what you're doing, tell me what you're doing, and tell me what you're using in conjunction with each other. It's, if somebody puts on a radial tire on two sides of the car, one side of the car, two wheels, and the other puts on a belted tire, now I'm dating myself, those don't work well together. But the manufacturer says, radial tires are fantastic, there's nothing wrong with my tires. The belted guys go, mine's great, I don't know what's wrong with your tires. That's what happens in dentistry. You buy, as dentists, individual products, and then you use them in a cumulative fashion. And each of the manufacturer is only responsible for what their product does, not what it does with somebody else's product. That's kind of where I found my little niche. So what Dimple did there with a whole bunch of our product and a few others, we'll get into, if you can pop up those slides, that next one.
Sorry about that. I was messing around a little bit. Okay, there you go.
There we go. So going to the next one here, what Dimple and I kind of orchestrated this a little bit. There's a couple things she does in her steps. And I thought, well, it makes sense to explain why she's doing what she's doing and maybe why that product can do what it does. Now, it's interesting with disinfection, Dimple actually modifies the tooth structure 3 ways. First thing's air abrasion. A lot of people use air abrasion. Not a lot of people use air abrasion and phosphoric acid and then use a self-etcher on top of it. But there's some reason behind that. The abrasion is great. We know why, because it opens up all those different areas of the tooth. We change that topography. We've got all this micromechanical retention, increased surface area, which bonding agents love because that's little finger holes that they can get a hang on. The phosphoric acid, we know why we're doing it, enamel and dent. And as Dimple said earlier, we're getting rid of the calcium, rid of the phosphate, and then we're leaving all those collagen fibrils. and we've got access to our tubules. Because let's face it, a bonding agent doesn't work unless it creates tags, right? You've got no retention, which I'm not going to go off on a tangent, but sometimes we should talk about desensitizing before we put a bonding agent on. Just think about it this way. A desensitizer like Gluma, fantastic as it is, fills a parking spot in a parking lot. That's a tubule. When you put a bonding agent on top of Gluma, the bonding agent's got to get in the parking spot that's already filled.
Mm.
So we'll talk about that a little bit later. Anyway, so let's go back to the Fedora Bond U, the self-etching side. So now we've got a self-etching adhesive on top of a tooth that's already been totally etched. I'm going to throw out a caveat right here. Not every manufacturer supplies a universal adhesive in the industry today that will allow you to phosphorically acid etch the entire tooth. Some will let you do selective etching. That's cool. Some will, like for Fedora Bond U, allow you to do not only selective, but total etch. And what's the concern? If you've got a universal that you're not supposed to phosphorically acid etch first, why would it be an issue? Let's explain how self-etchers work. Every self-etching adhesive, be it a Clearfill SE or an OptiBond, doesn't matter. Whatever self-etcher you're using, the acidic monomers in that bonding agent actually are looking to your prep for some nutritional value. That nutritional value is a smear layer, that hydroxyapatite, that calcium, and that phosphate. And when a manufacturer tells you to scrub your universal all over the tooth for 20 seconds, they're doing it for a specific reason. The acidic monomers actually liquefy that smear layer, incorporate the smear layer into the bond. And then what you end up doing is you end up filling your tubules with your patient's smear layer, natural, and a synthetic bonding agent. But during that 20-second I was talking about massaging, that's a key timeline. If a manufacturer says 20, do not do 10 or 12, do 20. I don't care if you do 30, but it's going to get messy and sticky and stringy, and you're not going to like it. But try and hit the 20. Like Dimple said, she has a timer for etching. Put a timer on for your universal as well. I would say 20 seconds for Fedora Bond U, because here's what happens. I start with a pH of 2.3, acidic. You massage for 20 seconds. My acidic monomers mix with the calcium and the phosphate in the hydroxyapatite. And during that 20-second process, my pH changes to a pH of 7, which is neutral, which means all the tags that we're going to create are pH neutral. If you shortchange the manufacturer by 5 or 10 seconds, you, my friends, will end up with acidic tag formation. And that will result in systemic post-op sensitivity for some patients. So you have to be very cognizant of that, which is one of the major reasons some manufacturers will not allow you to total etch the tooth, because if you take away all the smear layer, there's nothing for that self-etch to neutralize with. And it most definitely will be acidic in quality. So that's the only thing I want to mention about the etching protocol that Dimple's been using here. If we can go on to that next slide, Dimple. Admire Fusion X base, apparently use it every single day. It's an interesting product. Dimple made a comment, it's a nano Ormesser. So Ormesser is only manufactured today by one manufacturer in the world, and that happens to be Voco. But it's not a new technology, it's an old technology from the late 90s. It's a biocompatible product, which over the last 20 years has really, really escalated. There are more patients today that are BPA sensitive or material sensitive coming into our practices than ever before. So you've got the biological group, and then you've got the biomimetic group. And for me, internationally, those are the two emerging groups, polarizing groups in dentistry and restorative work right now. But that Admire Fusion Extra Base, it's a 72% filled. It's a flowable, which isn't massively filled, but to put it into context, probably one of the most popular packables in North America would be a 3M product, now called Saventum. And that would be Filtek Supreme Ultra. To give you an idea, base of reference, Filtek Supreme Ultra is a packable, creamy packable, but it's 78% glass. This flowable is 72, but it's a flowable. Now, nano, we all know everything's nano these days. Little tiny glass beads are spherical. They play a huge role in a flowable material. When you're looking to get that nice pulpful floor, all flowable self-level, by the way. Don't be confused by marketing that says people spent lots of money to make something self-level. Even a glass of water self-levels, and it's worth $0. So all flowables will self-level, right? It's just how long will it take? Think of the nanoparticles as little ball bearings. When you flow that material into that prep, it basically self-levels immediately. So you get this wonderful adaptation to the pulpal floor. All the surface irregularities are taken care of. You've got a nice stable dance floor to dance on. And of course, you can light cure out away or not. It's up to you. Because it's only 1 millimeter thick, maybe 2 millimeters thick, you can transilluminate that because it'll do 4.5. So it's easy to cure. From there, Dimples going into the packable and then bringing up that Admire Fusion Extra. They're both Admire Fusion family members. The Extra is a weird product. It was brought out in 2015 as a posterior bulk fill material, not an anterior, just a universal bulk fill shade. 4 years go by before Chicago Midwinter when Tokiyama came around and brought out a product called Omnichroma. And Omnichroma was this omnichromatic product that did A1 to D4, the classic 16. Fantastic. Did require a blocker, but it still did 16 shades. What we did was we went and looked at this product that was 4 years older and looked at the way the light transmitted through it and said, wait a minute, this actually matches A1 to D4 and bleach. So 17 shades. I started talking about that product, AFX, post-COVID, because as we came out of COVID, so many clinicians had lost product through office shutdowns. You had multiple shades. Everybody who's a wet finger dentist has run out of a particular shade on a Tuesday that they needed for Mrs. Johnson, only it wasn't in operatory 2 where I thought it was. And then you have to use something else. The omnichromatic single shade thing, that's a godsend. Because if you use the Admire Fusion Extra, you never have the wrong shade.
Mm-hmm.
It matches everything there. And it's not so much the material as the ability of the material to not hinder the light entering the restoration. As the light enters the restoration, it goes straight through the filler particle, straight through the resin, bounces off the tooth and comes back up to the naked eye. And in so doing that, it picks up all the coloration of the surrounding dentition. And I'm going to throw a caveat here in a second. So if you've got a nice class 1 and it's an A1, you can put that in and it'll look like an A1. If you've got an A4 tooth, it'll look like an A4. Here's the caveat. If you've got a class 2 amalgam that's sitting adjacent to it, and you put in any universal like this single shade, it'll look like the majority of the tooth, but it'll have a lovely silver halo right where the adjacent amalgam is. It'll pick up a little bit of silver tint to it. So just be aware of that. If you got a patient comes in with an MO and it's an amalgam that's failed, then they're going to remove it. They get a nice sexy composite. That's great. If they've got an adjacent that's of a similar vintage that's an amalgam, it's an OD, then, you know, or another MO, you might want to consider doing both at the same time and keep them happy. That's it on the Admire Fusion. Can we go one more, Dimple, just to see what else we've got there? Okay, it was the final occlusion. Polishing on this, there's nothing special about the polishing requirements here. It's an 84% filled product. You can take any of the polishing systems that are in the marketplace today and get a very, very attractive looking finish to it. Dimple, you've used it all the time. Is that a fair statement? Would you say that it shade matches?
All the time.
Okay.
All the time.
All right. Very good. There was one thing I did neglect to mention, and I was thinking about the base. When we line with a flowable material as a base, you have to be very aware of the compressive strength of that material. Because as the flowable goes in as a base material, be it a bulk flow flowable or regular flow, you should always know what the compressive is. Because if you think about it, the flowable is the foundation upon which the pyramid is being built. So if you think of it, you go to a football game and you've got the bottom row of the cheerleaders, it's all the big guys on the bottom. And then finally the girl at the very top is 104 pounds soaking wet. She's light at the top and it's heavy at the bottom. It's supported that way. When you do flowables on a class 1 or a class 2 as your base incremental layer, you invert the pyramid. So you put the weakest thing at the bottom and then build everything up above it. So compressive strength becomes key. That Admire Fusion Extra base has 260 megapascals is where the compressive is. And to give you spatial awareness on that, a normal molar structure, 2 structure, is somewhere between 240 and 300. So it's kind of right, sandwiched right in the middle between where a natural tooth would be on its compressive values, which really is why that product does so well as the foundational or supporting cast member for that Admire Fusion Extra when you place it on top. So those are the kind of things I wanted to just pull out as we were talking about the technique. But other than that, it's an awesome technique, I think. Anyone else? Dimple, you want to say anything there? Or Pam?
Well, we certainly got a bunch of questions. So
Okay.
I will just fire away. So first one is about the lubricant that you applied. You applied Vaseline to the tooth. Why not use water-soluble lubricant like KY instead of Vaseline, as microabrasion may not remove all the Vaseline?
So when I initially placed the lubricant, I did that more so for adherence. So if I were to place KY or glycerin, I feel as though it's a little too slippery. And you're going to remove the Vaseline because you're going to prepare the tooth, you're going to air abrade, you're going to etch, and so forth. So kind of like what Gregor said, you're using 3 different techniques to disinfect the tooth. So I'm not really worried about that Vaseline, but I'm also worried that I don't want adhesion and I don't want slipping and sliding. I got to make sure that stamp is accurate and it's going to stick and it's going to be easy to remove. I feel like the viscosity of Vaseline is just right and it's perfect. And again, I'm not putting a lot. I just gently kind of glided it over the tooth so that way there's no adhesion.
Dimple, did you use the micro brush on that just to kind of cover the peripheral areas?
It
on your-
was it wasn't a micro brush, it was like just a little brush.
like a sable brush, like an artist
Yeah,
brush?
exactly. Yep.
Awesome. Are you using a composite heater to lower the viscosity to be certain that your stamp
Ooh,
is
that's a good.
seated? And there was a
Listen,
question about how do you, okay, yeah, let's go to that first.
no, it's not needed. I don't have heaters. The consistency, the viscosity of the Admira Fusion is so perfect that there's no need for it. And that's what I love, is that when you even pick composites such as this, you really got to make sure you know the viscosity of the composite. We've all been in that tug of war with composites. Like I'm sure you guys can relate, is that you have a stiff composite. You put it on the tooth, it falls in the mouth. Now it's in the mouth. You look at your assistant. The assistant tries to grab it with her instrument. Then she tries to give it to you. Then it's now it's on your instrument. It's contaminated. I mean, I don't want to play those games. The consistency is perfect. So that's one turn off for me, is any sort of composite that has that sort of stiffness. But this is perfection.
Awesome. I've tried this technique and it's very difficult to handle Teflon tape without it getting all bunched up. Do you use a wider Teflon tape, like a 3/4 inch versus a 1/2 inch? And have you found a Teflon tape that is medical grade? Or are you doing what kind of all of us are doing and going to the Home Depot line?
You know, I bought this Teflon tape so many years ago. I bought them in bulk. So it's not Home Depot, it's not medical, it's called Amazon. So that's my shout out to Jeff Bezos. So it's Amazon Teflon tape. I don't find it difficult to handle because I'll cut a little strip and I just kind of gently layer it over. So I'm not playing with it. I have my assistant cut it and then it's almost like this piece of paper. Just lay it over the tooth and then let it set, and then I'll put the stamp in. And remember, the consistency of the Admira Fusion is just right, where it's not sticking to the Teflon, your stamp's not sticking to the Teflon, it's just the right type of consistency. So the minute I remove the stamp, I gently take cotton pliers, remove it, and boom, it's already stamped, ready to go.
Awesome. Can you use this technique for class 2 restorations?
Yes. Yes, you can. Most definitely. And it's funny because that's how Gregor and I first started discussing our class 2 techniques with that.
Right.
Meaning MODO versus OL? Like, so you can do an interproximal.
Yep.
Okay. Interesting.
OL might be a little bit challenging, right? Because if you got to manipulate your stamp and make sure you have the perfect angle and curvature. I don't know, that's a good one. Maybe I'll try that.
I think placement of matrix and the selection of the sectional becomes paramount here. I mean, there's a
Okay.
lot of great sectional systems out in the marketplace, but some
Right.
have, different anatomically shaped matrices than others. Some that are a little more, what's the best way to describe it? A little more exaggerated almost in their curvature. And I think if you're gonna do a class 2 with this technique, you need that solid wall in order to be able to create that stamp on that occlusal. So, I mean, I can think of a few products, like some of the really highly filled flowables that are in the marketplace. There's a plethora now. Well, not a plethora, there's about 5 or 6. But some of these materials are great for building that IP wall, that interproximal missing wall against the actual matrix by drawing the material up the matrix, and they're stiff enough that they stack and they don't fall down. You can actually light cure them. I've got a clinical series where I actually show somebody building a wall out of it, and then they remove the sectional and they use the composite wall they just built as their class 2 wall. So it becomes, they turn their class 2 into a class 1. But that's almost a step you would have to take to make this stamp work. Otherwise, you're going to be rolling over, kind of cascading over the edge of the cliff into the abyss, approximately. Yeah.
But again, the consistency has to be just right of that flowable.
Yep, absolutely. Yeah.
I would also imagine that we should get comfortable doing class 1s and then kind of go from there.
Right.
Right?
It's like riding the bike before you take the training wheels off. Yeah.
Exactly.
Do the class 1, then lose the wheels. Right.
So how do you know that you're fully seated? And then how do you make sure you've got all the excess cleared off?
So when you create the stamp, so again, this goes back to the consistency of the composite. I sometimes even put a little dot, so I know, okay, this is the lingual, this is the facial, this is the mesial-distal, right? So you got to create your own symbol system there if you're confused on where to go. But I'll seat it with some pressure. And it's almost like probing, right? How do you know you're at the base of the sulcus? It's all tactile feel. And you'll know because that's as far as you're gonna go. And that Teflon tape is really thin. So it's gonna press in accurately exactly where you need it.
Okay. And then making sure you clean off all the excess.
So I use that Ivoclar instrument, the Optrosculpt. It's kind of like a little styrofoam condenser, and I'll just gently remove any of the excess that I find that's visible. So once that stamp goes on, then it just kind of clears the way for everything. So you'll see like this excess just flow over.
Awesome. So, okay, this is a bonding question. When you have a large preparation, like an MODB on number 30, and if you're supposed to scrub your bonding agent for 20 seconds, would you say that each area gets like 5 to 8 seconds of active scrubbing, or should you increase your scrub time with the size of the preparation?
I think your scrub time has to be proportionate to the surface area you're covering. So what I might do is handle in 2 sections. I might use 1/2 of a large surface area and apply the bond to that 20 seconds. So that portion of the pulpal floor, the vertical walls that I've got there, and make sure that I'm engaging those acidic monomers with that residual smear. And then, go to the opposite side and finish off that location there. Because my fear is if you go beyond the 20, what's going to happen is it's going to become quite stringy. Because what's happening over that 20-second period is we're getting evaporation, right? All the adhesives have carriers, either acetone, ethanol, or combinations thereof, and they're all evaporating as you're scrubbing. So when you over push that limit on the timing, things start to drag and get sticky. The perfect, Dimple may not have done this, but sometimes people talk about the Futurabond U and the fact that it's a dual cure adhesive. Well, it is a dual cure adhesive, but it requires some dual cure chemistry to work with it. It requires some tertiary amines to bore from maybe a dual cure cement or a dual cure buildup, but it's not a dual cure in the packet by itself. And what I mean by that is I pressed here, popped a little blister, and then mixed the materials, and then just sat it there and went home on a Friday. If I came back on the Monday, all the solvent has evaporated, but the material hasn't cured because nobody's put a curing light on it. But if I opened up the foil, it would be the consistency of that adhesive on the back of your brand new credit card. The one you rub off and then you sign immediately. At least that's what they tell you to do. But that's kind of what happens to it. And that's exactly what happens when you over manipulate the product. 20 is what I want for neutralization. So these tags are pH neutral. 30, not so good. You're not going to be happy. You're going to start pulling things across and away from tubular. It won't obturate as well. So I break a large surface area into 2 sections.
That's really
Can
good
we
advice.
talk about brush size though? Also,
Oh, yeah.
when
Brush.
Yeah, whenever I'm doing any sort of posterior composite restoration, I will tell my assistant, okay, get this color brush out, this color. I have an array of brush sizes, so that way we know, okay, what increments are we working in? So I'll say teal for the smaller one. No, get out the blue. No, get out. It's almost like small, medium, large. So the larger the surface area, the larger the brush head.
Right. Yeah. And of course, the smaller with the minimally invasive preps. I gotta share this story with you. This is an absolute, I tell this in lectures because this happened to me. We give away little strips of 5 of those little pouches with some brushes. We send them out as samples. You know, it used to be in whatever the magazine was, it was advertising. You say, hey, circle 34, and you get some sent to you. I had a doctor call me one day, and I did this many years ago, 20 years ago. I put a toll-free number and I forwarded it to my cell phone, which sounded really cool at the time, but don't ever do that. Don't ever do it because people call it. And it doesn't matter what time of the day is, they will call it. But anyway, this doctor calls this toll-free number and says, I've got samples of your future bond. And I said, I didn't want to say Futura bond. That was rude. But I said, okay. She goes, yeah. And there's a problem with that packaging. I said, really? She said, I really like the packaging. It's a great little concept, the blister. And I pressed here and the little dome popped up at the other end. But there's a problem. And I said, what's the problem? She goes, I cannot get the brush to break through the foil. There's something, the foil's too thick. I said, really? Which brush did you get in the package? Was it the yellow or the blue one? Because we shipped out different ones. And doctor goes, no, I use my own brushes. And I said, okay, understand. She goes, I've got teal, I've got pink, I've got white. And I said, great, okay. And what's happening? She goes, well, every time I try and pop through the foil, the brush bends. I said, oh, that's not very good. I said, well, wait a minute. What kind of micro brushes are you using? And she goes, oh, it's a bender brush. I said, it's a bender brush and it's bending. Okay, have you got one right there? I think we've got the solution. I said, get the pouch, get the brush, spin it 180, poke the handle through, spin it again, and go. Are you good? She's laughing out loud on the phone with me. She's chuckling away to herself. And after she gathers her composure for a couple of seconds, she goes, oh, I'm so sorry. I can't believe I called you about this. I said, that's okay. I can't believe you're a dentist. I didn't actually say that. I might have thought it, but I didn't say it. But
I
just
love
on that
hearing
little
that story. I heard it.
here,
I like it.
just remember that. If it's really tough, use the handle and then spin it because sometimes brushes are too small. Anyway, that's all I got for that one.
Or just call you at 2 a.m. and
No, don't do
get
that.
the
Don't do
answer.
that. That toll-free number now is not working anymore, fam. I've just delisted it.
Oh yeah, no, I've taken my phone number off my email signature for that very reason. Anyway, let's talk about self-leveling flowables. What about on a maxillary tooth? Does it level away from the tooth or does it level onto the pulpal floor?
Depends on what position you've got the patient's head, I suppose. No, it's when we talk about self-leveling, it's very interesting. There was a product 14 years ago, Surefill SDR. It was the first fill flowable. And they actually took a glass and they showed the material like a little mountain of material, like a little pyramid. And then he said, this is it when you initially place it. And then he showed another glass and it was slightly lower. And then he showed a third glass that was completely level. And he said it was self-leveling. On the bottom of the graph, he said it was time, but they didn't tell you how much time. Might have been 6 hours or 4 minutes or 24 days. I don't know what it was, but they all self-level. To Dimple's point about viscosity here is crucial. You want to have it runny enough. That's not a technical term, but runny enough that will actually cover the anatomy and all the pulpal irregularities in that floor, because very few clinicians, I know there are some, but I don't know many that can cut a prep like a plate glass window with no anomalies to it. So you need to get it self-level, but you also need to have a modicum of thixotropicity, which means you can place it and then talk to somebody and it's still there and it hasn't run right off the tooth and they've ingested it. And I think we've got 3 different flowables that follow that religion. And so too does the AdmiraFusion Extra Base. It really doesn't run much at all. Dimple, I mean, what do you say?
No, it doesn't run it much at all. And you know what, Gregor, you need to talk about the tip. What's
Yeah.
so unique about this tip? that you use for these flowables, and why are we using them?
So the tip that you're talking about there is a very long needle tip. It is bendable, so you can actually change the angle on it quite easily. But you're going, okay, so what, everybody's tip does that. Everybody's tip does do that. But I want everybody to visualize a Starbucks straw standing straight up. And then I want you to bend the straw halfway on a 90-degree like that. And then just see what happens right at that 90-degree. There's a massive knuckle that develops. And that knuckle pinches the straw, and then you'll pass out if you're trying to draw a thick drink up through that straw. You just can't get in a vacuum. That's the problem with needle tips. So when you bend them, they kink. The Germans came up with a very interesting but expensive way of doing things. And they made it what we call kink free. Not kinky, but kink free. So that when you bend it, the knuckle doesn't actually stay there. The tube stays open. Why is that a big deal? Is it over engineering? It is kind of over engineering, but it's a necessity, because what it does for you as a clinician is it reduces the back pressure, so that when you're actually extruding the material, the product doesn't increase its pressure and cause the tip to move up and down, which I'm sure somebody's heard of someone else who's had bubbles in their flowable. That's because of porpoising on the tip. So that's one thing about the needle tip. Probably what Dimple was leading to was the syringe design. It's called an NDT syringe, non-dripping technology. Let's face it, with every flowable you've ever, you push down on a plunger, the material extrudes, it flows out the end of the tip. You stop pushing on the plunger and it continues to flow out the tip, which is why we all reach for the plunger and we pull it back. Again, I don't know why nobody did this before, but the NDT syringe, if you cut the actual syringe in half, just slice it in half and flip it open, you'll notice there's an interesting coating on the inside of the barrel of a syringe. It's almost like it's not like a popcorn ceiling, but it kind of looks a little bit like that if you can get that visual. And then where the plunger is, there's a silicone donut. It's almost like an endostopper. So what happens here is when you extrude and you apply pressure on the plunger, that plunger starts to compress the material. And as the material is moving and the plunger is moving, the little tiny gasket gets compressed. The donut gets flattened. So what happens when you stop pushing the plunger is the silicone donut rebounds back to its original shape within a split second. And what that forces is a little bit of vacuum right at the end of the needle tip. It'll draw it in about 0.5 millimeter. The result, when you do it visually, is I give somebody the syringe, say, hey, try that, like extrude it onto on a card or a piece of paper or something, stop pushing the plunger, and then doctors go, okay, what's this? And they extrude again, they take it with a syringe, and there's no run on at all, no dripping, no stringy. It's gone. That is a patented syringe. Every flowable viscosity that we make is in that non-dripping technology. And if you say it in German English, it is non-dripping technology, it is NDT, it is super sexy, yeah. That's the way the Germans are, uber sexy. So it's functional. It's not sexy, but it's functional and it's unique. Is that what you were talking about, Dimple?
Yep.
Yeah, that's kind of what I thought. Yeah.
That
I
is
get excited
awesome.
about tips. You get excited about the plunger. But
I
anyway,
mean, I think at the end of the day, it's about efficiency, right? Just like
right.
we discussed this technique, it's just about being efficient as a clinician and making sure you deliver what you're meant to deliver without having a patient call you back or feeling any sort of sensitivity or discomfort or whatever it may be.
Right. It's an interesting concept.
It's an extremely interesting concept, and all of us have dealt with the extra extrusions after a syringe, and it's not pleasant, to say the least. Okay, we have 2 more questions left.
Yep.
And one, how do you prevent the composite from sticking to the Teflon tape?
You know, I didn't run into that issue. I've been asked that before. So I haven't cured the composite, right? So maybe that's another thing that we need to incorporate is that once I've over bulk flowed the composite, I'm placing the Teflon immediately over it. And so it's a barrier. And then I'm placing the stamp technique. And then once I remove the stamp, remove the Teflon tape, then I'm curing it. So I didn't have any adhesion factors or any stickiness with that.
Okay, so maybe that's and your fancy Amazon Teflon is maybe different than some other
Yes.
Teflons out there.
I have a few different shades of the Teflon, but for this purpose, I used white.
Nice. Okay. Can you touch upon the proper use in case for dentin sealers? This dentist says that they found many patients who had less sensitivity with it. I'm curious about the effect on bonding. Also, should it be rinsed off as per the manufacturer's recommendations or dried as per the dental experts' recommendations?
Now, I'm going to assume here we're talking about when you're talking about immediate bonding sealing, you're talking about taking a desensitizer, or you're taking a bonding agent and actually sealing the dentin itself to eliminate the sensitivity. So
I think I thought we were talking about Gluma.
right, okay. So I always classify that, and sometimes it gets gray. I always classify it as a desensitizer. So it's
Yes,
interesting you ask,
Gluma.
because that's a very common question, especially at lectures. Someone will take you to a sidebar and say, hey, so what's your take on using Gluma first or a desensitizer? And it's a bit of a circular discussion. It was so prevalent, probably about, I want to say about 6 years ago. CRA, Gordon Christensen, decided to answer that question. Gluma's been around since the dawn of time. I mean, not really, but I mean, it feels like it has been, and it's a phenomenal product. And people were saying, well, if I put Gluma down first, is it going to inhibit my bond strengths, or does it improve my bond strengths? So what Dr. Christensen did was he took 7 different adhesives and he measured their bond strength to dentin. Then he applied Gluma to the teeth and then applied a bonding agent and measured all 7 again. And the interesting thing was, it was a bit, unfortunately, it was twofold with the results. One, nobody paid for the study, as in nobody being the manufacturers actually funded the study. And the problem with that is we don't get, shall we say, transparency. We don't get clarity. What we got were 7 different products. And the response was some materials worked better with Gluma placed down first. Others, there was no difference. And a few others, the bond strength was reduced somewhat. But no names were mentioned. All the innocents were protected. So nobody knew. We still didn't have an answer. Does it work better or it doesn't? I'm old school and I just kind of go on physics and logic. And I look at it this way. If you fill the parking spot, and Gluma is quite viscous. So if you fill the tubule with Gluma, you have now obturated the tubule. So you're not going to have sensitivity, because the old physiological stimulus is a patently open tubule that results in post-op sensitivity. And if you seal and obturate, you don't have sensitivity. So when you seal it with Gluma, no pain. Perfect. Now when you put a bonding agent on, especially the newer generations, I'll give you an example. Clearfill SE, when you put Clearfill SE on, it was about 20 to 60 microns of film thickness. That's what the bond was. OptiBond FL, fantastic product, 32 years old. Almost 100 microns of film thickness is average for an OptiBond FL placement. Now go to like Scotchbond Universal, 9 microns, like one less than 10, one more than 8. Tiny. Futurabond U, 9 microns. That product doesn't have a whole lot of muscle. So if you put a viscous Gluma or desensitizer in there, and then you put a universal adhesive that doesn't have a whole lot of strength, it's very difficult for them to cohabitate. If you have a bonding agent that's a similar viscosity to that of the Gluma, then you can have cohabitation. Is it as deep and profound a resin tag as one would like? No. But the thing is, do we need 100 microns, or can we get away with 65 microns? And the reality is we can get away with 65 or 40. So it's not a lost cause. The question I always say to dentists is this: the cost of Gluma is free. Everybody gets Gluma for free. I heard that. Anyway, it was like they used to charge 160 bucks a bottle. Now it's free. No, it's still 160 bucks a bottle. The first thing I said is, if you're using Gluma, why don't you buy the product that copied it as soon as the patent came off? And that involves Ray Bertolotti, Denville Engineering, and the product is called, right out of my head, it's a desensitizer, the exact same chemical formulation as Gluma. Someone might know it. If anybody knows it, put it in the box.
Microprime
Microprime,
G5.
thank you, and Microprime F. Those are the two. Ray basically copied the formula for Gluma, and it's about half the price. So that's option one. If you want to save money, it's all about money and time, and it is. You want to be sure about the Gluma, buy the Microprime F. I do not get paid anything. I no endorsement for that, but it's still a great product. Or other option is you've already got a bonding agent, and the way you get a good bond strength is by accessing tubules, sealing, obturating tubules, which is the exact same physiological sealing process that a desensitizer does to eliminate sensitivity. So if you took an extra 10, 15 seconds and judiciously placed your bonding agent all over and didn't put a desensitizer down, would you effectively get the exact same outcome? The answer is logically yes, because you're getting obturation, you're getting great primer penetration, great tag formation, and your sensitivity is virtually nil. I've got to say, most doctors that went to self-etching adhesives from Total Etch saw the frequency of post-op sensitivity kind of disappear from their practice almost overnight. The dentists didn't get magically better. They were already really good. It just, that technique changed the way things were done, that material. So take that with a grain of salt and look at your desensitizing protocol and do you need it? For a cervical portion or application, absolutely. Gluma all day long, no problem on that. Take away that, cervical sensitivity for patients. The problem with putting a bonding agent there, which you can do, is bonding agents are inherently hydrophilic, which means if you do a cervical third on a patient, it's going to pick up Coke, red wine, tea, etc. So you're going to see a little gradual stain at that cervical margin just because the bonding agent's there. But they won't have any pain. They'll have to change their clothing colors. That's all.
Well, thank you both so much for your insights and your recommendations and your just overwhelming knowledge of the science. That was really interesting. And I see why you're called Grugel, just saying. So
Right.
there were a couple of last minute questions about the stamp technique on class twos, but I don't think we have the time to get into that. So maybe you guys will just have to come back and we'll have to revisit the class two stamp technique.
Sounds good. Okay.
All right. Well, everybody, thank you so much for joining us for DE Solutions Lab. I'm thrilled that you did. I hope you got something out of it. I know I certainly did. For future DE Solutions Labs, follow us on Instagram, Dental Economics Official. If you want to see this Solutions Labs or other Solutions Labs from the past, go to our website, www.dentaleconomics.com. You'll see a tab there called Solutions Labs, and this one should be available probably sometime next week. So if you need to revisit it, please, by all means, do so. Thank you again so much for joining us, and I look forward to seeing you all next week. Have a wonderful Labor Day and a wonderful evening. Take care.
Thanks. Take care.
Thank you.
Bye-bye now.
Bye.